Hey, good afternoon, everyone. TJ Alls, I-45 Now and Galveston Now. Welcome to another edition of Healthcare Unmasked, our second of four special programs in the month of October, focusing on women's health and breast cancer awareness. Obviously, October is Breast Cancer Awareness Month. And if we're going to be talking about this subject, none better to have on with us than Dr. Suzanne Klimberg, who is, I got to tell you, Doctor, it's one thing to it's one thing to be the division chief of surgical oncology at UTMB and also be a professor. But as folks will find out as we go through this show, some of the groundbreaking work you have done in breast cancer, particularly, and we'll get into this about being able to do surgeries, but also where it's less invasive. And so everything from less pain and the like, and we'll be getting into that. So thank you for coming on with us. We do appreciate you coming on today to bring your expertise to the show
Thank you for
today.
the invite.
One of the things I just wanted to go into right off the bat is that you have done a lot in UTMB and in your career overall to minimize the after effects of breast cancer treatments, and particularly in the surgical areas. Can you talk about some of those areas that you've worked on that have, in many ways, they've been groundbreaking along the way?
Thank you, TJ. One of the things I'm excited about right now is a trial that we have, a national trial that I'm the primary investigator for, is preventing lymphedema. Lymphedema is arm swelling that occurs after surgery, and it can be as much as 25-30%, depending on what kind of surgery you have. And so what we're doing is a procedure called the arm procedure, because it's for your arm, so it's easy to remember. And we map the lymphatics out of your arm as it goes through the armpit, and where we often operate and can cut those lymphatics. So this identifies them and allows us to protect them. If you go back to that last slide, I've had so many people tell me that these are actual quotes from patients. Lymphedema is worse than the mastectomy. I fear lymphedema more than the cancer. Lymphedema reminds me every day I have cancer. My clothes don't fit right. People ask you about why you're wearing a sleeve on your arm, or why is your arm swollen. And, it's a little bit of embarrassing. And so you want to, and then you're at increased risk for infection. So you want to prevent it if at all you can, for sure. Nobody wants any harm. So it can be very devastating for patients. So
We're
what
taking a
we
look at
have
an
done
image
is
right now.
pardon me?
Just for our viewers, so they understand what we're looking at here, is an imagery here where a patient has in the left arm that lymphedema is in that massive swelling there, and it gives folks an understanding of just the physical reminder, as you had pointed out. But also can be painful for folks. And as I've been watching one of your informational videos before we got onto this, can be something that can increases the infection rates for folks as well. And I'm sorry to interrupt you. I just wanted for our viewers to be able to understand what they were looking at here.
Yeah, it's a devastating picture, isn't it?
Yeah, it surprised me in going through the material you had sent over. Again, if you're just joining us, Dr. Suzanne Klimberg, she is a professor and the division chief of surgical oncology at UTMB, and is at the forefront of a lot. And one of those is you had just talked about axillary reverse mapping, arm technique, and we're seeing part of that here now. Walk us through this video that we're looking at here.
Well, just to back up a second, so this patient's had breast cancer. You can see the incision on the breast itself. And what we do is we want to find where the cancer drains to. A cancer that's just a radioactive. We put some radioactivity in the breast. Here you can see in yellow or gold around the tumor, and let it drain to the first draining lymph node, which is called the sentinel lymph node. And then the arm concept is to identify what's in blue. And if you move forward, you can see it, we can follow it as it goes through the axilla. Now, just to go back to the the cancer on this slide, the cancer drains the breast. And the primary place it drains to is underneath the arm. And if you think of cancer sort of like a computer, if it's hooked up to the internet, in other words, it's invasive cancer, it can go, the first place it drains to is the lymph node underneath your arm. And so that's the one we want to check. And if it's positive, when we do a little bit more surgery. And at about 4% of the time, it can be the same lymph node that's draining your arm. And so if that happens, we actually do surgery in the operating room to put those lymphatics back together if we have to take the lymph node draining the arm. If it's the same as the breast, we want to know if it has cancer in it, because that gives you a higher risk of lymphedema.
And when we were talking about this in our pre-meeting about this was a technique that you had developed, even came up with the acronym for it. How long ago had you approached this, and why did you approach it the way you did? I mean, what convinced you that this was something that really needed to be tackled in this manner?
Well, I've probably been working on this 20 years. Our first publication was about 15 years ago.
Wow, a long time.
Well, I was on some of the first trials for sentinel lymph node. We were on the first publication, the phase 2 trial, and then the randomized trial, in which we went around the country training people for sentinel lymph node. At the time, everybody was doing axillary dissections, and so this was in the early 90s. And so we, as part of a NCI grant, went around training surgeons how to do a sentinel lymph node. And then, so we watched them do radioactivity in the breast and how to find it with basically a gamma probe or what's a Geiger counter. So we would find it, the sentinel lymph node. And then to prove that it would work, we had to do an axillary node dissection, the standard of the time. And so I watched everybody do an axillary node dissection. And what happened is that everybody does it differently. And if you look in the literature, the rate of lymphedema can be anywhere from a low of 7% with an axillary node dissection to 77%. So it ranges all over the place. So what I said was, well, we can do this better because not everybody's doing the same surgery. The sentinel lymph node, we taught them how to do the same surgery. But even there, with this trial, which ended up with a sentinel lymph node lymphedema rate of 8%, we taught them to do the sentinel lymph node and take any palpable nodes around it, which isn't necessarily what we want to do, because we know the arm node can be right next to the sentinel lymph node 8% of the time. So we really, that's not how we do sentinel lymph node today. We take what the radioactivity lights up, basically like a flashlight lighting up what the thing you want to see in the dark. And we take just that one, we send it to the lab and see if we need to do anything further, or have we gotten the prognostic information that we want. So that's how I started doing it. And I said, well, we're looking at what's coming from the breast. I want to save what's coming from the arm, so why not map it too? And it's basically split mapping, mapping what you want to take and mapping what you want to save. But they cross over, 4% of the time and are close to each other about 8% of the time.
Right, because you're working in close proximity during a surgical, and in the end, it becomes a more efficient surgery when you're taking that work. You're only taking out what you need to.
Well said.
That's the biggest part, is it not? It's
yes.
And that means less pain, less recovery time, all of that, and you're getting to what needs to be the source to get out of the way.
And less lymphedema. The lymph node, my sentinel lymph node rate is less than 1%. I published 654 patients several years ago, and less than 1% lymphedema rate. And for a full axillary node dissection, which across the country is 25 to 30%, my personal one in that publication is 6%.
And one of the things it gets into, I have heard this from many women over the years of the biggest fear that they have is the pain that will come after having some type of breast surgery, whether it's mastectomy or removing a lymph node or the like. That's what holds them up from even doing follow up. But I found it fascinating in my conversation with you. There's a ways to minimize that a great deal. Can you talk about some of the methods that are being used now that maybe not 100% across the board of alleviating pain, but there are steps being made now that weren't available maybe 20, 30 years ago, or weren't being used as a regular practice to lessen the pain and focus on pain management in this situation?
Yeah, I've written quite a bit about this, and we use at UTMB, we use a lot of trigger point injections, pectoral blocks, rib blocks, latissimus blocks, teres blocks. And so we, during surgery, before we even start, we use local. And before we even go back to the operating room, we give you some medication that starts the relief of pain. So if you can block pain before it starts, then you can decrease it enormously. So we have a whole regimen that starts before you even get to the operating room. And if you have a problem with nausea, we have a regimen for that as well. But I think if you block the pain, you block a lot of the nausea that comes along with surgery as well.
You shared a fascinating story with me. I wanted you to share with our viewers too of a patient who had surgery, and at one point, because of the surgery and pain, couldn't move an arm. But you did a couple of things, and next thing you know, for the first time in a while, she was able to move her arm. Share that with our viewers. I found that just fascinating.
Yeah, I get sent a lot of patients like that with frozen shoulder, and they get sent to PT, which doesn't help a whole lot. Sometimes it can be very helpful, and I'm all for PT, physical therapy, excuse me, and this is somebody who was operated elsewhere, and since that time when I came in to introduce myself and shake her hand, she lifted her arm up with her opposite arm, and she couldn't raise it over her head. She couldn't lift it by itself. She had pain in the breast and the chest wall, and she had some trigger points in her back along the scapulothoracic bursa, which is the ones that are the ball bearings that the shoulder blade moves on, and that's how you lift your arm and even turn your neck. Sometimes it can go up into the neck as well. And so I gave her a couple of trigger points there, and then I was talking to her a little bit longer about something else, and I said, well, try and raise your arm up now, and she lifted up straight up 180 degrees above her head without any assistance. And so if you get the right spot, and then we also use heat and things like Aleve or Motrin or Tylenol to get the inflammation out of the shoulder. Because if you get and I'm talking about not this, a lot of times people will have a rotator cuff, but it's actually pain referred from the back of the shoulder blade.
And that, how is that different now? Taking approaches like that than say 20 years ago. I had a doctor once tell me, he says, the techniques we use now, which are more efficient and more targeted and less evasive along the way of not only making the patient's life better, but when you compare the two, it's as if we jump centuries in advances. And I would think the time you've spent in that, you would have maybe a similar perspective on that.
Oh, yeah. I would say 20 years ago, we would give a lot of pain medicine, narcotics. I would typically not let anybody leave without some narcotics in hand. And we still give them, nobody wants to be at home with pain. I've been at home with pain and can't find the dentist. I know that I personally know that I don't want anybody to have that. So you always have a few backups and a number to call. But in general, we don't let people today use very few narcotics, if at all. A lot of patients don't take any pain medicine, but we really want them. And I've had patients call up and say, I don't have any pain at all. I'm really worried that there's something wrong. So people
Right.
often expect to have pain, and it's really nice when they don't. Not, nothing's 100%, but that's what we strive for.
Well, and also too, I was reading up. You had mentioned it to us in our pre-meeting yesterday, but also in reading up on some of your literature that you have out is that so many procedures now that you have non-invasive procedures that would have been evasive procedures before. Talk about some of those, because I find that even fascinating, because I think there are a lot of people who have still this kind of concept of, if there's any type of breast surgery has to be done, it's getting all the saws out and it's going to be incisions everywhere, and it's just going to be a tough road to hoe. But there has been so much steps that you have done yourself of making things less invasive in the overall process.
Well, for sure, TJ, with non-invasive cancers, or excuse me, what do I say, benign, fibroadenomas, et cetera, that bother folks, they're painful, or they are, or you can palpate them and they worry you. We can percutaneously, with a needle, of special needle devices, we can just excise those percutaneously, so we don't have to make a big cut in the breast. We can make a nick in the skin, introduce the device, and take out the benign tumor. So that's one thing we can do. The other is, I'm an oncoplastic surgeon, and I teach oncoplastic techniques internationally, and we make incisions, hidden incisions, so that you don't have to have a big scar on the breast most of the time. If it's involving the skin, we have to take some skin, but most cancers are going to be a little bit deeper, and what we do is remove them through a hidden incision, and able to take them out with a good clearance of the tumor, if that's what you mean.
And also too, I had found in talking with you in this was the how the steps are going now on diagnosis. It is the thought of always, well, it's got to be the mammogram, or it's got to be the procedures of going in the clinic. You're actually working on some clinical trials, so some pretty exciting stuff of using teardrops. Talk about that, the tears, because this is something that I don't think anyone has heard of outside of maybe the medical circles, but talk about that, because this is exciting, really exciting stuff.
Yes, we've collected tears from over 700 patients, and used it to find some proteins in tears, which we have a patent on, that can diagnose breast cancer with a sensitivity and accuracy of nearly 90%, which is actually much better than a mammogram. Now, mammograms have to be used in concert with this. This can be an easy, we're trying to prove, and we're collecting more tears to prove that that this is a useful way to screen the population, because it's low cost, probably costs about $10 for each test. And it can, my dream is to have it on the countertop, just like a pregnancy test, where you can go in and purchase it. And if you're worried about something, you can figure it out right away. Now, my dream hasn't been realized yet, but
right. Yeah.
we're getting closer. So we're doing another round of testing at UTMB with patients with cancer. We're still taking tears just to try to improve it, but I would expect within a year we'll hopefully be out on the market so that we can utilize that.
That quickly
about it.
To be on the market within hopefully a year there. How did this come about, that you were able to understand, as we're looking as showing you at work in many ways here, but how did that come about, that we can use tears to do this?
I was coming back from a job interview 20 years ago. And I was sitting next to a eye executive. In other words, she worked for an eye company, and we just started talking about eyes. And I started thinking about eyes and tears, and that's basically. And then we started looking at it, and it's going to be just more than I've got data for ovarian, I've got data for colon. There's going to be a whole platform of cancers we're hoping. And the nice thing is there's no blood involved, because tears is a filter of blood, and so that you have you have a sterile solution you can put right on a little slip, and see, honey, you made me cry, I'm going to test for cancer now. So it's just another way to make you guys feel bad.
Yeah, but it could be a good thing too. You said something here that I also want to make clear that yes, it's the what you're working on now is with to be able to diagnose and with breast cancer, but it could be used for any type of cancers possibly
Yes.
along the line.
Yeah, that's the dream.
How long have these clinical trials been going along?
Oh, it's at least 10 years or more.
Wow. That's amazing. Please keep us updated on that, because that is just fascinating. When you brought that up,
any rich people that want to send money,
where we need to send it to,
we can make it go faster
to do that. And that gets me into that next question to ask you is what's the future hold for not just testing but treatment too? Because when you have breakthroughs on being able to diagnose, that's usually followed not too long behind treatments that are better than what you had before.
Well, one of the papers we just published is, and this goes to the whole field, most of the time we are treating folks that don't benefit from our treatments. In other words, only a certain percent of people who get treated with chemotherapy will benefit. Only a certain percent of people, approximately, I can tell you with small tumor, favorable tumors, about 14 to 16% will benefit from taking endocrine therapy. But we treat everybody. We're hoping to benefit the few. But now we have genetic tests that we can perform on the tumor, oncotype, mammoprint, those type of gene tests on the tumor, so that we can tell who's going to be really aggressive and need chemotherapy, who only needs endocrine therapy. And I just finished a paper that we published that showed that if you have a very low oncotype, that you, at least in the short term, you don't really benefit from endocrine therapy. And patients have a horrible time with a lot of chemotherapy. With some of the surgeries we do, with any kind of treatment, there's always people who don't benefit, who might have side effects from it. So we've been trying to focus in on who really needs what, and not over treating people who don't really benefit. And so that's where the whole field of breast cancer is going, and it's really leading the charge for all types of cancer, really.
You had mentioned how about your dream on the clinical trials go through. There's always the dream of anyone that deals in oncology, fighting cancer, the dream of that super treatment that can take care of it all. That may not ever be a reality, but you jokingly says you've been around long enough, you've taken your age out of your CV. So I will not to, as I said, I don't like to age anyone on these deals, but what is your hope now for eventually making what may be fatal cancers now into manageable in the, say, next 10 to 20 years as it was when you first came into this field?
Well, I know you've already had Dr. Robinson on, and really screening is the key. Getting your regular mammograms, doing your self-exam. It's really not really rocket science. Finding cancer early, which, our risk of finding non-invasive cancer has gone way up because we're finding earlier and earlier, and that's the thing. Take care of it early, and I'm hoping that the tiers will also be more sensitive and and be able to screen, because we have good screening techniques that are underutilized. People, are it's between 40 and 60% of people really utilize their screening properly.
And that gives us into a kind of a good segue here of an event coming up on the 20th that UTMB is part of, and that is Broad Day. There's a lot going on, including some screenings that are available as well, plus some giveaways as well. As happening on October the 20th, and it's online. It's via Zoom. That you can take part in this, and we can put the links to that up in the chat area now for you to take a part of as well. And I think right now we were double checking on this. I think the registrations may be full, but we're going to double check to get the gift bags. But do be a part of this, and you want to submit your questions on that. As the University of Texas Medical Branch honors breast cancer survivors for National Breast Reconstruction Awareness Day. That's where BRA, BRA, it's an acronym in that. And as always, Kendra Scott is part of that as well, which is always exciting to have as part of that as well. Dr. Klimberg, thank you so much. And matter of fact, I love it here as we've because already from what you have given here in our short amount of time, as you can tell, we've had many of you come on already and complimenting you on what you've done. I always ask this of someone that comes across as having the passion that we hear in your voice about this. And I have to ask you personally of what brought you to oncology, and particularly in the areas that you're working now. That because there's always that kind of end goal, but you've made so much groundbreaking research, and are still doing that. At what keeps you motivated?
Well, my partners in crime, so to speak, the breast surgeons are an interesting group of surgeons, and they're very passionate about lessening the morbidity and mortality of breast cancer, surgery, chemotherapy, radiation. And at UTMB, we have such a great group of Dr. Hatch in radiation therapy. You've already met Dr. Robinson and Dr. Silva, my partner. I'm not sure. I think you've got her on coming on. And so and then Avi Markowitz. We just got so many good team players at UTMB, and I'm sure I've left somebody out, but they all are very passionate about what they're doing. And so exciting, and we're participating in research. We've got a great group in our clinical research who's led by Lori Simon, and just a really wonderful group of people trying to do the right thing and trying to lessen the morbidity and the harm that we do to patients without any benefit. So that's really what our aim is, and this is a national thing too. The American Society of Breast Surgeons had the honor of being president of. It's just a wonderful, passionate, zealot group of surgeons, and so it's very exciting. Everybody's trying to do everything possible to make things better.
Well, it's my grandmother, who was a breast cancer survivor, then eventually passed of that, would always say, "You're doing God's work, Dr. Klimberg." So we appreciate you for the work you've done, and we appreciate you coming on today. A reminder to our viewers, as soon as we wrap this up, you can go back and watch this. We have some links in there. You're seeing the site where you have, if you look up, just go online, look up UTMB Health breast cancer, and the breast health section can come up. And this is all your resources, whether it's for yourself, a loved one, where everything from questions you may have on mammography, breast cancer care, support groups, and the like, which we'll be talking about in the near future as well. Plus, you can find out more about the team at UTMB Health on this, and the link we have as well too about for Broad Day is in there as well. So make sure you check those out. As I said, this was the second of what we're doing. There's 4 shows this month. Normally, Healthcare Unmasked is done just once a month, but we are doing this every week throughout. The next show next week, Surviving Breast Cancer, Reconstruction, and Patient Support. Dr. Julie Park will be on with us, surgeon, one of your, as you said, one of your partners in crime over there at UTMB. And then UTMB Health Cancer Support Group's director, Saran Hillman will be on as well to talk about the support group aspects of things, because I know you would support this, and that this is not just an individual coming in, getting surgery, and getting well. It takes a village, is the lack of a better term here, getting feedback from other people, not just for the patients, but also their families.
And all of our patients are presented at a multidisciplinary conference, so we get that collective wisdom, if you will, to make the right choices for each individual patient.
And then our final show of the month is coming up on the 27th, and it's connecting the dots between women's overall health and breast cancer. Dr. Jerome Yaklik will be on with us, and then Dr. Tanya Callender also will be joining us, and that'll be on the 27th. Each of these shows is at noon, and we want to make sure you join in with us. And we take your questions. We had a lot of comments on this one today, but no direct questions. You're answering them all well already, Doctor, and I appreciate you coming on with us, Dr. Klimberg. And it's an honor for me to have you on the show. Your reputation is one of the best in this world, and as I had told you, I have my grandmother had passed away from breast cancer. I've had other family members, and every single time we looked up research on what's the best treatment or what's this or that, your name kept popping up every single time over the years of doing so. So to finally meet you in person in this way and do so, it's an honor for me to have you on. So thank you for coming on. I do appreciate you spending the time. I know you've got to get off. You've got to get off to your next thing as well here in a few minutes. So thanks for coming on with us today. I appreciate it.
You're very kind. Thank you so much.
All right. Dr. Suzanne Klimberg's been on with us again next week. Join us again at noon here on I-45 Now, Galveston Now, as well as 288 Now and Clear Lake Now, where we'll have Surviving Breast Cancer, Reconstruction, and Patient Support. Then the week after, we'll be talking about connecting the dots about overall health, and that's a bigger topic we're going to be tackling for the next year of folks making sure they're taking care of your general health to get to those more specific things. Until next time, I'm TJ Olds, I-45